FDA will accept the BLA end of this year. Concurrently, registration in Australia, Thailand, Philippines, Vietnam, Turkey, Chile, Colombia, other country in progress. Last month, we just received the first overseas foreign inspection from Chile. To develop this product, I remember the first talk on SY023 when I invited by Dr. Rupert was 2015, before any clinical trial. After 6 clinical trials, 4 in healthy subject and 2 efficacy trials in category 3 patient, the product was first approved by Chinese regulatory agency. But the approvals is for patients 18 years older adult. It's very typical drug development, adult first. Then what does it take to expand the label to pediatric population? So phase 3B. We proposed 2 clinical trials. The first one is a PK/PD safety trial in children less than 18 years old, all the way down to 1-year-old, 12-month baby. And the study designs 108 healthy subjects, 1-to-1 randomization, 023 with a rabies vaccine versus H3 rabies vaccine. The primary endpoints, safety, and PK/PD. The results, AE adverse events, it's very minor. It's safe and well tolerated, and very much similar to the trial result in adult population. The AE are mostly site of injection reactions. Monoclonal gave lower level of pain, swelling, and redness. So it's actually a very important for doctors in the field. It's much easier to inject monoclonal than H3 because viscosity is only about 20%. So very safe product, just like adult. The PK parameter similar to those in the adult studies. Pediatric PK, PD, so you can see the left-hand side, here we call seropositivity. Dr. Rupert may object 0.5 IU per mil, but that's what regulatory agency use. If you look into the percentage of subject with seropositivity, the H rate would take 7 to 10 days to get to close to 100%, greater than 0.5. But 023, the salient feature of SY023 is it gives very high dosage. And so even after 1 day, you reach over 90% of seropositivity. By day 2, day 3 is 100%. And the concentration or the titer is much higher than H3 on. The second study, which is ongoing, we did first one's healthy subject. The next one is the real pediatric patient, category 3 exposure. The study would consist of 2 parts, primary study and extension. In total, 190 subjects, patients. This is a real-world evidence study. We target 190 patients, and there will be certainly about the same number of H3 patients as well for comparison. The primary endpoints, rabies-free survival, month 3, and 12-month follow-up. The safety to be studied as well. But right now, it's ongoing. To date, we have enrolled about close to 100 patients already with all good outcome. The next ongoing clinical trial is actually, to me, is very interesting. If you recall, I said it took us 2 efficacy trials, one in Philippines, one in China, a total 1,448 category 3 patients that followed for 1 year. And the scientific question is, how do you know those 1,448 patients actually were attacked by rabid animal, dogs and cats? It's unknown and unknowable. The principal investigator, China and Philippines, told me that it's just not possible to track down the animals. But that question always there. What's the percentage of those animals actually rabid? So in China this year, we conducted the study. We know in human we can't do challenge protection, even though we did 3 animal model challenge protection. Can't do it in human. But this comes as close as to the human challenge. Okay, the designs in rabies endemic region in China, Nanyang, about 10 million people. And in the past year, there are numerous cases of single dog biting multiple patients. And we knew that local CDC, when they capture the dog and perform direct fluorescence, the antibody, they can tell majority of those dogs are rabid. So we initiate a study in collaboration with the local CDC. Essentially, in the period of 6 months, we take all the single dog, multiple patient cases. It has been a little over 4 months already. See the number down there. There are 21 incidents, 21 cases of single dog running around attacking multiple people. And 44 patients were involved. It's not every attack for every dog, 2 patient. We only enroll adult patient because the product's approved for adults. So there are pediatric patients as well. That's 44. First of all, out of those 21 dogs, all of them were positive for rabies. And 44 patients enrolled in the study, they all show rabies-free now, at least 3 months. So I was a little nervous. No one has ever done this. This is challenge protection. It takes a lot of confidence on the product to initiate the study, but so far, so good. Well, of course, we'll do 1-year follow-up and report the results. Let's shift the gear a little bit. PEP failures. Here we'll talk about PEP. S1O23, all about PEP. When we work with academic people, we look into the documented failure, so-called PEP breakthrough. From 1980 to 2023, there were 124 cases of PEP breakthrough, which means PEP was performed, but patient developed rabies. About half of them actually could be attributed to some problem with the PEP procedure. At least half, the other half, no reason why PEP was performed, but patients still develop rabies. Especially recent cases, sporadic but high-profile failure in China and North America, Canada, and US. In China, if you have a PEP failure, well, it's all over internet. Everybody blame everybody else. So you know about it. The common characteristic of PEP failure, number one, severe wounds, especially head, neck, and face. This wound is so close to the brain. So you're talking about centimeter away from the central nervous system brain. Multiple bites, high viral load, multiple bites. Again, experience from the field in China. The doctors told me that, well, in some cases, multiple wounds from head to toe, it's very hard for them to be sure that infiltration of rig actually cover all the wounds. So it's very, very hard to say. So multiple bites enhance the chance of getting PEP breakthrough. Number 3 is immunocompromised. I think that's the case in most recent rabies in the United States. The key question, why does PEP fail despite timely administration? Here's a simple model of circulating antibody action. It circling muscle. When you have low virus load, the amount of antibody, neutralized antibody delivered by RIG, E-RIG, H-RIG, or antibody, sufficient to neutralize through the infiltration at the wound site. But if there are multiple bites, some wounds will not be given H-RIG or monoclonal. Or the amount, the titer is so high, so virulent, you could have spillover viruses outside of the protective zone provided by RIGs. And here's the salient feature of S123. Because of the high concentration antibody given to the patient at 0.3 mg/kg, this may reduce the PEP failure. So essentially, even in the circulation, you have greater than 0.5 IU per mil. And in theory, you capture, neutralize all the virus that spill over from the wound sites. I'd like to mention 0.3 mg per kg represent about 23 times of ERIC titer. ERIC is given 20 IU per kilogram. At 0.3 mg per kg monoclonal cocktails, 23 times potency. So when we look at the data and compare SY023 against two approved Indian monoclonal antibody in HRIG, these are all phase 3 clinical trials. And you can see that, the Serum Institute of India, the dose very low, 3.3 IU per kg. And Zydus Cadila, rabies maps, 40 IU per kg, but two monoclonals, they are both mirroring, not humanized, represent some risk over there. And the other two are HRIGs, phase 3 trial. The only SY023 offers very high circulating titer from day one compared to other options. If you look at the percentage of subject getting greater than 0.5 IU per mil, so-called seropositivity, S1023 stands out from day one. It's greater than 0.5 IU per mil. So this actually prompts another question that we ask about this subject, rabies treatment. The conventional wisdom tells us that if a patient develops symptom, it's almost 100% death in the rabies. Then we ask the question, if we can give patients, rabies patients, very high concentration monoclonal, would there be an opportunity to help? I certainly understand it's not possible to treat all the rabies infected patients, but can we help, especially early stage? So we developed a mouse model. We challenge the BALC mice with SC16, that's a dominant dog-derived rabies virus in China. As you can see here, these mice, after the challenge, it takes about 5 to 7 days to develop symptom. About 3 to 6 days after the symptom appear, they die. So the idea is we give these mice very high concentration antibody at 20 milligram per kilogram. The first day, the symptoms appear, the onset of symptom. That's usually 5 days, day 5. From day 5, then daily injection of 20 micrograms, very high concentration.
We are running out of time.
Okay, good. All right, and you can see here, the treatment actually offers some protection. With this tantalizing results, we ask many questions. First of all, can high concentration, almost last one, concentration of circulating antibody effectively penetrate the blood-brain barrier? That's a big question. Some say 1 to 1,000, maybe 1 to 10,000 antibody can push the product antibody into the CNS. Is there a window of opportunity for using SY023 in rabies treatment? We don't know. And I feel fortunate. Doctors in the US and China are both interested in this. Can SY023 enhance the current treatment practice in US, such as Milwaukee Protocol? In China, Beijing University Hospital also interested in this type of treatment study. So maybe next year I'll report some results of rabies treatment. Okay, that's all I have. Thank you very much for your attention.
Thank you. Thank you, Dr. Sao. Well, we don't have time for question, but maybe one very short question for Dr. Sao. Okay, so we have to move forward. Thank you, doctor. Thank you very much for your nice presentation. We have to move forward. We have some announcements. Sergio, we have to depart from here at 5:30 okay, and we are going to move these the posters mentions for tomorrow. So I see you at the entrance of the building at 5:30 to go to the gala dinner.